a Synoptic pathology report for anal cancer. Welcome to the Everything Surgery podcast, where we dissect the extraordinary. Today, we will walk through a comprehensive pathology report for anal cancer, emphasizing the unique histological features, clinical staging, and treatment approaches that distinguish this disease from other cancers of the lower gastrointestinal tract. Let us begin with the patient profile. The individual in question is David Miller, who underwent a medical procedure on November 28, 2023, following concerns about a palpable, ulcerated mass at the edge of the anus. With a background of persistent high-risk human papillomavirus infection, the clinical team proceeded with an examination under anesthesia and collected tissue samples for diagnostic and staging purposes prior to initiating definitive chemotherapy and radiation therapy. Upon gross examination, the specimen consisted of multiple irregular fragments of tan white tissue, with a total size measuring approximately 1.2 by 0.8 by 0.5 centimeters. All tissue was submitted in a single cassette for analysis. Microscopically, the sections revealed fragments of squamous mucosa infiltrated by an invasive, moderately differentiated squamous cell carcinoma. The tumor was composed of irregular nests and cords of atypical squamous cells, notable for prominent keratin pearl formation and intercellular bridges. This was accompanied by a dense lymphoplasmacytic response in the surrounding stroma. The cancer originated from the surface squamous epithelium, which itself demonstrated changes consistent with the high-grade squamous intraepithelial lesion, also known as carcinoma in situ. Important prognostic features were assessed in the sample. The histological grade was classified as moderately differentiated. There was no evidence of tumor invasion into blood vessels or nerves, and, as expected for a biopsy specimen, margin assessment was not applicable. Ancillary studies provided further insight into the biology of the tumor. Immunohistochemistry for page 16 was strongly and diffusely positive in more than 70% of tumor cells, supporting the role of high-risk human papillomavirus infection in the development of this cancer. In situ hybridization confirmed the presence of high-risk human papillomavirus RNA, specifically type 16 and 18. To summarize, the diagnosis was that of an invasive, moderately differentiated squamous cell carcinoma arising in the anal canal. The tumor originated in a background of high-grade squamous intraepithelial lesion, with no evidence of lymphovascular or perineural invasion. Biomarker studies confirmed an association with high-risk human papillomavirus, offering a favorable prognostic indicator. It is important to note that, unlike cancers of the colon or rectum, the staging for anal cancer relies primarily on clinical assessment, including physical examination and imaging studies. The pathologist's role is to confirm the diagnosis and report relevant prognostic features, rather than assign a tumor stage based on biopsy findings. Anal cancer, particularly squamous cell carcinoma, accounts for the vast majority of cases in this anatomical region. Adenocarcinomas are rare and behave more like rectal cancers in terms of treatment. The diagnosis is typically established through a biopsy rather than a surgical resection, as most patients are treated with chemotherapy and radiation rather than surgery. High-risk human papillomavirus infection is a key driver of disease in more than 90% of squamous cell carcinomas of the anus. The presence of page 16 positivity serves as a surrogate marker for human papillomavirus oncogenic activity and is considered a strong confirmatory and favorable prognostic test. Like cervical cancer, anal squamous cell carcinoma has a precursor stage known as anal intraepithelial neoplasia or high-grade squamous intraepithelial lesion, which was present in this case and highlights the progression from viral infection to dysplasia and ultimately invasive cancer. The staging system for anal cancer is based on clinical findings. Tumor size and extent are evaluated through examination and imaging, not by microscopic evaluation of a resection specimen. Tumors smaller than 2 cm are considered early stage, those between 2 and 5 cm are intermediate, and those greater than 5 cm or involving adjacent organs represent advanced disease. The absence of perineural invasion is reassuring, as this feature is associated with higher risk. The confirmation of human papillomavirus-associated squamous cell carcinoma on biopsy leads directly to treatment with combined chemotherapy and radiation, a protocol that is curative for most patients. Surgical approaches are reserved for salvage therapy in cases where standard treatment fails or in rare scenarios where radiation is not feasible. In summary, this pathology report delivers the vital information needed for the oncology team. confirmation of invasive squamous cell carcinoma, evidence of its human papillomavirus-driven biology, and the absence of high-risk features such as perineural invasion. These findings will guide clinical staging and facilitate the initiation of non-surgical, organ-preserving treatment. Thank you for joining us on the Everything Surgery podcast. If you found this discussion insightful, please like, share, and subscribe for more deep dives into the world of surgical pathology and beyond.